Cheers. So this is a picture I took from my book by Anne Osborne, Neuroradiology, when I was a resident. So if you look at it, I tried to memorize all these things. याद नहीं रहेगा कभी भी, है ना? I mean, it's impossible to remember this thing, right? So I made over here little bit of my mnemonic over here on that page कि शायद इस तरह से याद हो जाए, वो भी याद नहीं रहता है. लेकिन what happens is that when you practice, you do cases and you see those cases, तो आहिस्ता आहिस्ता that accumulates और फिर वो याद रहता है. फिर भी so if you look at it, this is how Anne Osborne divided it. So she basically put as frontal horn separately. This one, she put this as body of lateral ventricle, and then basically atrium of lateral ventricle, जिसको जहाँ ट्राइगोन आके वो हो रहा होता है, occipital horn और temporal horn, ठीक है. Then foramen of Monroe region, and then this is third ventricle, posterior third ventricle and cerebral aqueduct, right? और ये aqueduct का दिया हुआ है, और फिर ये fourth ventricle. So again, there are a lot of tumors which will occur in a lot of these parts, but then each of these ventricle has slightly more predilection. For example, medulloblastoma आपको fourth ventricle में मिलेगा, यहाँ पे it's a rare case report को मिल जाए, right? Not over here. But the frontal horn में अगर adult में आप जाएंगे तो you will see these two things more commonly, neurocytoma and lymphoma, right? Or in children, which you may find peanuts and Sega's subependymal giant cell astrocytomas, and then polycystic astrocytoma. Foramen of Monroe के region में, इस region में यहाँ पर anterior third ventricle, again ज़हन सबसे पहले आता है colloid cyst, right? So I didn't label that, but then central neurocytoma may be pushing in that region. और उसके बाद in child germinoma, sega, cranipharyngioma going from below up there. So there are a lot of lesions that will actually come from which are not typically intraventricular, but then they project intraventricularly. So you can't really say if they are intraventricular or not on an MRI, but you have to look at very closely and see where are they arising from, because that may change the approach of your surgery when you come to those lesions. अच्छा, फिर इसी तरह when we come to the body of lateral ventricle, again neurocytoma and oligodendroglioma. So oligodendroglioma are not so common in the past 20-30 years ago, or so, maybe 30 plus years ago. Neurocytomas were classified as oligodendrogliomas. And then Yashar Gill, actually, neurosurgeon, he told our neuropathology colleagues and published a paper. Actually, that's a neurocytoma. So I think you don't find oligodendroglioma in the lateral ventricle, but then there can be rare instances of oligodendroglioma, which I have seen. But then a lot of times oligodendroglioma from the brain parenchyma can grow inside and give the impression of intraventricular tumor. But then if it's a purely intraventricular, then it's more likely to be central neurocytoma if it's a glial tumor. But then there are other tumors as well, right? Uske baad, then meningioma for some reason are more common in this area. Not frontal horn, not body, not occipital horn. So occipital horn, why not? Because meningiomas arise from the choroid plexus areas. So choroid plexus just goes in this, like this over here. So but then choroid plexus is in the third ventricle also. But for some reason, meningiomas are more in the atrium area. Lymphoma you can again see over here because there's a thick splenium over there crossing right next to it over here, right? So the thick splenium is going to, just like we have butterfly lesion lymphoma anteriorly in the forceps minor, इसी तरह posteriorly we can have, in the thick part of the corpus callosum, the lymphoma can occur there. But then not only lymphoma, then you have oligodendrogliomas, and you have high-grade gliomas, glioblastoma. So they can all grow there and project intraventricularly also, and give you an impression of an intraventricular lesion. अच्छा, उसके बाद, so in occipital horn, that's pretty much rare to find tumors in there, in this area. So if you notice over here also, not much, because just a pure ependymal lining. Over here, it's a choroid plexus that's going like this. And the choroid plexus, there's a lot of inclusion with the choroid plexus and all that thing, and that's why you find all these tumors. And then in this region over here, as the brain is developing, there's a lot of developmentally aspect के लिहाज से देखें, so there's a lot of changes that are happening over here, which give rise to different kind of nest cells, give rise to tumors. अच्छा, उसके बाद when it's pure temporal horn, then we have again maybe meningiomas, some calcifications, NF2 vascular malformation talks about. In the fourth ventricle, besides these three, medulloblastoma, polycystic astrocytoma, जिसको पहले कहते थे juvenile polycystic astrocytoma, and ependymoma. ये तीन, remember these, you can call it, MEP or medulloblastoma, ependymoma, polycystic astrocytoma, or MEA, MIA, से आदमी याद रख सकता है नाम. And then there are others, so you can have choroid plexus papilloma in child also, and subependymoma, but they are more common in adults, subependymomas. And then you find epidermoid, not so much dermoid, more of epidermoid growing in there, which give an impression that this is like an arachnoid cyst. And then, there are a lot. So there, for example, if you look over here, it doesn't talk about arachnoid cyst, right? But then you can have a big lesion over here as an arachnoid cyst in the ventricles. It's a cyst, it's a growth, just like colloid cyst. You can find colloid cyst over here, right? So arachnoid cyst also, it's a mass lesion, right? So there's so many tumors coming in here. It's not really easy to remember. You just have to remember these specific things. So I will come to I will come to let's do it this way. Okay, so that's good. So okay, so I'm gonna ask, randomly we're starting. This is a young male, right-handed, and he came with generalized tonic-clonic seizures, right? And if you notice, so we can start with someone. Mustafa, would you like to mention what we see in here? Young male with seizures. Where is the lesion? Is it intraaxial or extraaxial?
First, it's an intraaxial lesion.
Okay. T1 में हमें क्या नजर आ रहा है? Just describe it.
So on T1 cells, there are mixed signals, ISO to hypointense.
Little bit of starts here and maybe here a little bit, but generally isointense, है ना? Pretty much, like if you look at the date, it's pretty much same. T2 में हमें क्या नजर आ रहा है?
So in T2 में भी जो है तो mix iso-intense है, but mainly it's hyper-intense, and so it's a basically irregular lobulated structure in right occipital horn, and so there are mixed intensity signals in T2 as well.
ठीक है, और फिर उसके बाद इसमें जो है contrast पे क्या हो रहा है?
So contrast में it's usually showing the almost homogeneous enhancement.
Right. So and then this is a flare, and in flare you notice that again it's pretty much iso-intense, right? थोड़ा बहुत heterogeneity है, not very smooth like white matter. On ADC, it's pretty much a low signal, right? है ना? और ये जो है SWI में हमें क्या नजर आ रहा है?
So SWI में जो है सर इतनी ज़्यादा susceptibility नजर नहीं आ रही, just on the
Right.
periphery.
Right. But then there's a lot of vessels that we're seeing in here, right?
Yes, sir.
A lot of vessels in seeing in here. So I mean, a young man, and I would, so temporal horn यहाँ पर आ रहे हैं, so I would call it atrium का है tumor, right? जिसको हम लोग ट्राइगोन का भी कहते हैं, right? So atrium में है tumor, and if we go back, so atrium में अगर आप देखें, atrium ये रहा, and adult है ये, so meningioma आ रहा है ज़्यादा नहीं, हाँ, cyst तो नहीं लग रही, chloroid plexus नहीं लग रही, lymphoma भी नहीं लग रहा है because it's like projecting वो, so it looks more like a meningioma. अच्छा, enhance कर रहा है, intensely enhancing, and ADC पे low है, right? कोई edema भी नहीं है इसके आसपास, so you don't see a lot of edema over here, and then a lot of blood vessels, right? So meningioma, अगर if I say meningioma, या कोई कहे तो उसको मैं नहीं कहता, गलत नहीं है वो, right? And then we have some answers, yeah. So but it turned out to be a choroid plexus papilloma. Right? So it goes to show the reason I have put this case as first case. Okay, guys, try to remember possibilities as what is more possible than, but don't don't corner yourself कि नहीं यही है वो, because I remember we did this case recently, and I remember that I was thinking about meningioma, and when the pathology came out, choroid plexus papilloma, I was surprised. So we had them check the pathology again, and it turned out to be choroid plexus papilloma. Okay, लेकिन once again the features are the features that you want to note कि है कहाँ पर. So if I start with that, it's not in the frontal horn, it's not in the body of lateral ventricle, it's in the atrium, right? And I see that there are blood vessels right next to it, and ISO intense hai, low on ADC hai, no hemorrhage and things like that inside, but a lot of vascularity. So meningioma and choroid plexus papilloma would have been two possibilities, right? Okay. Why am I stuck? Okay, all right. So we have, all right. Okay, so now let's look at this one. Another young male. जी हाँ. Well, I mean, मैं बताता हूँ, ठीक है मुस्तफ़ा. Well, ये बताइए, चलिए, हाँ, आप बताइए, please. Go ahead.
सर मैं बताऊँ या किसी और जो है participant?
और कौन बताएगा? Anybody interested?
I think Dr. Yusuf is interested.
Okay, Dr. Yusuf, please go ahead. Yusuf, आपकी आवाज नहीं आ रही है.
I'm sorry, sir. Just turn on the mic. So it seems to be the screens are shifted. Yeah. Okay. So there seems to be an intraaxial lesion, possibly on the trigon on the right occipital horn of the lateral ventricle. It is it's hypointense on T1 and hyperintense on T2, and seems to have heterogeneous contrast enhancement. In fact, we see that the patient has low signals on ADC, and on DWI the increased signals is possibly an element of diffusion restriction. And however, आवाज नहीं आ रही?
नहीं आ रही, मुझे आ रही. I can hear you. अब आप म्यूट कर दिए अपने.
Oh, okay. And however, I do not see any susceptibility or signal dropouts in SWI images. So I cannot really I don't think it's a really vascular lesion. So I do agree that it seems to look somewhat like a meningioma. So I'm sorry if I called it an intraaxial one rather than an extraaxial one. But that would be my primary differential over here, actually.
Okay, good. So, so once again, look at the similarities between this case and this case, right? Isointense, sort of little bit of mixed signals on T2, intense contrast enhancement, low ADC, some vessels over here, choroid plexus papilloma nicolago. Same thing, isointense, little bit edema over here though. But I don't know how you can really say things because even choroid plexus lesions can also, when they start to invade. But it's pretty good enhancement. Yeah, slightly regular. Low ADC, vascularity थोड़ी सी कम है. So let me show you more about this thing. Okay, here we go. Little more information here, and notice that how it is attached to these blood vessels. Notice this blood vessel coming from the choroid plexus to it. See this, right? These are important ones, and there's edema around it. Okay, and then I think, and
Yes, sir.
and then you see now यहाँ पे क्या ना मुश्किल है whether these are veins or these are arteries, but then there's all the vascularity over there. So this turned out to be a meningioma, right? And but again the atrium of the lateral ventricle in area hai, not in the occipital horn is going over here. Occipital horn is going over here, right? So not in the occipital horn. It's more in the atrium. But just look at the similarity. And these were the two cases that we did not too far apart, I think, within a month or so. Interesting to see this similarity. Okay, moving on. So this is from last year. A gentleman. Okay, ये कौन बताएगा मुझे इसके बारे में? कोई है जो बताएगा मुझे इसके बारे में?
Dr. Faidan, if you're willing.
जी.
Dr. Nasser wants to speak.
Dr. Nasser, हाँ. Go ahead, please.
So in the first one, we see the first image is T1 plane, the second is T2 axial, and third is T1 post contrast. Then we have sagittal cuts of the same T2, T1 post contrast, and flare images. It appears to be a well circumscribed lesion that is centered in the fourth ventricle, coming up from the roof, from the floor of the fourth ventricle. And this is showing there is some cystic component in the periphery, but in the center there is mostly a solid component with homogeneous intense contrast enhancement. And in the flare image, we can see that it is also hyper intense. It's almost up to the level of foramen magnum.
Right.
So, what's the age of this patient, if I may know?
Age, young gentleman. So that's like 24 years old. And
24 years old.
He presented with the let me see the history here. Presented with complaints of worsening drowsiness for 2 days. 2 days. So suddenly, basically, sudden symptoms are there, but no history of headache, seizures, vomiting, or loss of consciousness.
Right. So my top referential would be medulloblastoma and ependymoma. But so there is very rapid worsening of the GCS, obviously attributable to hydrocephalus.
Right.
I would say yeah, these two are my top differentials.
Yeah, go ahead, please. I'm listening.
No, that's it, sir. I was concluding.
Right. So yeah, so you are absolutely right. The symptoms, the sudden appearance of symptoms, was not because of the tumor itself, but sudden symptoms because of it just blocked, and you can see there's a significant hydrocephalus. Although there's not so much of transependymal fluid, right? So it looks like it's not that acute of hydrocephalus. लेकिन 2 दिन की history दे रहे हैं ये. And यहाँ पर भी, if you notice, there's not much edema around it. So the problem with these images are, or when you look at it, it's hard to really say, is it coming from the floor or is it coming from the roof, right? Hard to say. Is it coming from the floor? Is it coming from the roof? Kind of mushkil hai. But then, what are these other silent features that you start to pick up? Well, the whole fourth ventricle is dilated, right? So that makes you think that whatever is purely growing intraventricularly, right? It's not coming from outside, है ना? एक तो ये चीज आती है जहन में. उसके बाद there's not much edema around it, and इतना बड़ा fourth ventricle है, 2 दिन की history है, so it's something that is growing slowly over time, not very fast growing, not invasive, right? ये सब चीजें जहन में आ रही हैं. We are in the fourth ventricle, right? And the man is a young man, है ना? So what are the possibilities? The possibilities are metastasis, choroid plexus papilloma, subependymoma, dermoid and epidermoid, and hemangioblastoma. But you can't ignore that these patients can have medulloblastomas and parasitic astrocytomas and ependymomas, right? Okay, so if we go with that, medulloblastoma, it's purely intra wo lag raha hai, it is not going out, it's not so chance low. Parasitic astrocytoma enhance karta hai bada intensely, lekin usually parasitic astrocytoma would have ek second, usually parasitic astrocytoma would have a ring, a cyst kind of a thing. Ependymoma will not enhance so intensely. Metastasis, he's not really that age, 24 years old, but you always need to keep metastasis. But metastasis would have a lot of edema around it, would be stuck to some aspect, and it was like it was floating inside. Epidermoid, obviously, epidermoid will have no contrast enhancement, and only flare will show a little dirty picture, right? Hemangioblastoma, intense enhancement, but again, a lot of cyst around it. So choroid plexus papilloma looks more possibility, right? And if you look at that reasoning over here, right, there you go. So look at it, right? Ab yahan par na, so really, is it coming from the floor? Is it coming from the roof? Kana mushkil hai, because it's so big. And maybe there are some people who are very good in looking at these things. I'm not. I can't really say if it's coming from the floor, coming from the roof. But I'm looking at other features: intense enhancement, no edema around it, right? And obviously, it's going into the foramen of Magendie, and maybe in Lushka also. I don't have those pictures of Lushka over here. But so this goes more with the choroid plexus papilloma. Okay, that's reasoning. So we have to train our reasoning. We can't memorize everything. But in the background, you have to have this a list of things. You can't have a memory of everything. Lekin aista, or think about it. You're looking at the fourth ventricle. Ependymal lining से कुछ हो सकता है, choroid plexus से कुछ हो सकता है, और the surrounding wall में tissue में क्या glia है, वो सब चीजें हो सकती हैं. Plus remember few other things. अच्छा, उसके बाद let's see what their comments or something.
And it has a very frond-like appearance as well.
Very frond-like appearance. Exactly. Thank you. I forgot to mention that. Yes. I just want to make sure that anybody else has any comments. Okay. All right. Good. You know what? First of all, those who are putting comments in there, I have to say two things. The one thing that it's great that you guys doing it, and if you're sticking your neck out, saying a diagnosis, you are very secure. You're very secure. You don't have inferiority complex, right? You're saying this is what it is. You're wrong. So never shy away in this kind of forum to give an opinion. पता नहीं लोग क्या कहेंगे, मुझे नहीं पता, मुझे भी नहीं पता, किसी को नहीं पता होती बहुत सारी बातें. अच्छा, then so Rabit, how to differentiate subependymoma from choroid plexus? So this is not choroid plexus carcinoma, this is choroid plexus papilloma. So carcinoma will not have this kind of appearance. It will have more invasiveness and all that. और फिर उसके बाद जो ependymoma will be based on the you will clearly see, based on the usually on the floor of the fourth ventricle. I think I do have that picture also sometime here, somewhere. Okay, all right. Let's move on. Okay, ये कौन बताएगा? लोकेशन क्या है, कहाँ पर है, और what is the possible diagnosis?
And or Dr. Pradhan.
I thought Ahmad ने अपना वो on किया था, so I thought Ahmad was going to do that.
Okay.
Okay, sir, मैं बता देता हूँ sir. On the extreme in the upper image we have T1 plane, T1 is T2, and in the extreme right we have T1 post
There's a lot of मुश्किल हो रहा है मेरे ख्याल में.
Am I audible now?
Yeah, clear now, yeah.
Okay. On the extreme right, top image, we have T1 post contrast. The middle image is T2, and on the extreme left, we have T1 images. The first one, and it shows the axial sections where we can see that there is some iso intense lesion at level of foramen of Monro. Again, we can appreciate this same thing. T2 में इतना अच्छा नजर नहीं आ रहा, but we can appreciate the same thing. There is rounded iso-intense lesion on T1 post-contrast, which does not show any contrast enhancement. On the lower images, we see that T2 sagittal. We appreciate this hyper-intense lesion at the level of third ventricle and foramen of Monro, and this can again be seen as a hyper-intense lesion on flare images. So based on these findings with some hydrocephalus or dilated ventricles, I would say these findings are most likely a colloid cyst.
Right. So this is pretty much a slam dunk kind of a case, right? Because the location of this thing, non-enhancement, right at the foramen Monro, both sides, hydrocephalus, यहाँ पे सब ependymal fluid काफी ज़्यादा है. It looks like it is more acute than the previous one, the previous person, this one. Although in this gentleman, he did not see that much of, right? See this? But he had a history of 2 days. And this gentleman had a longer history, I think. Okay. So, yes, colloid cyst, right? Anna? And, but then, occasionally you can find the wall, maybe sometimes with hemorrhages, sometimes this and that. Occasionally you can find some enhancement. But typically, no enhancement. And and there is no hemorrhage in this one, but then I have seen one with a hemorrhage also. This is a DC signal dropout nahi hai, it's all colloid fluid. CT scan, इसका नाम तो नहीं आ रहा ना, नहीं आ रहा नाम, ठीक. But so CT scan, this is another different person, a lady, I think middle-aged. Actually, some other surgeon in AKU took care of it recently. So, it looks like a hyper dense. It looks hyper dense a little bit. It can be more hyper dense than this one on CT scan. Okay. All right. So now let's talk about this one. ये कौन जो है हिम्मत करेगा इसके लिए?
I'll continue with this one.
Okay. Faizan, you don't know this case?
No, I have not. I don't, sir. So starting with the first, it's a T1 wave image. We can see a lobulated lesion at the frontal horn. It's pushing the frontal horn. It's iso to hypointense.
Right.
T2 is hyperintensity with areas of iso to hypointensity area of isointensity, and there is contrast enhancement with the area of hypointensity in the middle.
Right.
We have the coronal image. This is a flare image. It seems more with the area of isointensity area of hypointensity at the peripheries, and again pushing the lateral ventricle.
Right.
And then we have the sagittal image. It is, we can see it's a bit below the ventricle. It might be originating from the ventricle itself. Considering that it's coming from the frontal horn, I would think it might be an astrocytoma.
Very good, actually. So you're thinking on the right lines. So you're thinking in the lines of glioma, right?
Yes, sir.
Anna?
Yes, sir.
In the lines of glioma, and here in these images, it looks like that it is a purely intraventricular mass. But then here, if you look at it, it's arising outside the ventricle and it's projecting inside the ventricle. That's why it's pretty obvious over here. And it looks like that it's arising in these areas, where the basal ganglia and all that is, right? And from here, it's pushing inside.
Pushing
Uh,
upwards, yes.
but, and so it looks like it has blocked the foramen of Monro because of this push. So lateral horns are more dilated, and you can not really appreciate much of the third ventricle or skew wall compressed VV, right? If you look at the fourth ventricle, that is not much dilated either. So it's like it has blocked it's just like a colloid cyst. It has blocked that. Let's see if there's a picture on this one. I don't know. Let's see. No, this is a different one. So sorry. So yes, it looks like a glioma. Now, if you ask me, कि हाँ glioma है क्या होगा, it will be probably a low grade glioma. Maybe oligo bhi ho sakta hai. That's what I would think more about. But then contrast enhancement, I can't really put it together with a low grade glioma, right? So I'll go towards the higher grade glioma, right? But I will not go to the GBM or something like that. But this turned out to be gliosarcoma,
Oh.
right? So you're on the right lines. It's a not really an purely intraventricular lesion. It was arising from there. But the interesting thing is that it doesn't have a lot of edema around it. With the gliosarcoma, you would expect, have a lot of edema and all that. But then enhancement was significant. So that was going in the pushing it towards the higher grade, right?
Sir, just a question. Do we know that the patient was on steroids prior to the imaging?
Like steroids will not make so much change in that, and I don't think it was a long time. Okay, all right, all right. I don't have the history of this gentleman. Do I? No, I don't have the history. I just have the medical record number. Okay, so यहाँ पर ये कौन करेगा? Who's interested in doing this thing? Is this we took care of this recently, right, Dr. Ahmed?
Sir, this lesion basically is intraaxial and located in the left occipital node.
बात काट रहा हूँ. So the point ventricle के अंदर है. Is it intraaxial? Is it extraaxial? नहीं, it is intraaxial, right? It is intraaxial intraventricular, right? So somebody मैं देख रहा था कहीं पर कुछ वो था, कोई सवाल उठ रहा था कि is it extraaxial intraaxial? So I would call, as you said, Mustaq, it's intraaxial and intraventricular. Okay, go ahead. Just like कोई spinal cord lesion होता है, हम कहते हैं intradural and intramedullary. अच्छा, आगे चलिए. हाँ.
Basically, left occipital node से arise हो रहा है and abetting and causing effacing the left occipital horn. There are mixed intensity signals, ISO to hypointense on T1, and similarly, this lesion is showing some bright signals hyperintense and also ISO to hypointense signals on T2 as well. And effacement हमें यहाँ नजर आया left occipital horn की, and just a very slight midline shift is present. Or the compression pressure effect on septum pellucidum, right? And there's very heterogeneous enhancement, usually peripheral rim enhancement here. And on flare signals, so hai coronal में हम देखें तो so showing hyperintense and जो है as compared to surrounding parenchyma. And on sagittal cut, here we can see this lesion. जो है occipital horn से arise हो रहा था, or it's causing compression over the splenium of the callosum and causing mass effect over the dorsal aspect of brain stem, rectum वगैरह पे.
ठीक, good. So that's good. So I would still call it as arising from in the trigone area, in the atrium area. I will not go to the occipital horn, right? So it looks like it's arising from somewhere over here. नहीं लग रहा है ऐसा कुछ? Or maybe here, I don't know. मेरे ख्याल में लग रहा है मुझे यहाँ से जैसे लेटरल वॉल से उठ रहा है थोड़ा सा, राइट? एडिमा इसका थोड़ा सा है यहाँ पर, थोड़ा सा इसने पुश किया हुआ सेप्टम पेल्यूसिडम को. So I'll put it as a trigone, as a atrium area. So मैं इसकी हिस्ट्री पढ़ रहा था यहाँ पर. So this is a 21-year-old gentleman with no prior comorbidities, who presented to the ICU with headaches and altered behavior in December 2020, followed by memory impairment. तो ये इनकी हिस्ट्री थी, right? So as a progressive onset over few months probably, right? Acha, so let's go back to the problem is if I go so slow, it is easy to be a discussion, but then I can't cover everything. That's the problem. But then I think I would rather. Okay, all right. So फिर हम इसी पर आ गए, यहीं पर हम यहीं पर अटके हुए, या maybe we can include this also somewhere. It's somewhere over here, right? है ना? हाँ, अच्छा. So इसकी उम्र है 21 साल, चाइल्ड नहीं है. But then let's look at the list. PNET, teratoma, choroidplexus papilloma. So choroidplexus papilloma नहीं हो सकता, right? वो usually intense enhancement होता है. But then we have seen choroidplexus papilloma which was not enhancing intensely, है कि नहीं? हाँ, अच्छा. उसके बाद जो है anaplastic astrocytoma, it's more of a intensely, right? उसके बाद है GBM वगैरह नहीं लग रहा है. सबइपेंडाइमोमा, इसकी शक्ल वैसी लग नहीं रही है. सेंट्रल न्यूरोसाइटोमा इज अ पॉसिबिलिटी. Oligodendroglioma is a possibility. Metastasis is low because he's young, right? ठीक है. Okay, so coming back to it. All right. So यहाँ पर choroidplexus papilloma नहीं रख रहे हम लोग, meningioma नहीं रख रहे हम लोग, enhancement नहीं है, right? But it does not look like a high grade lesion. Edema इतना ज़्यादा, इतना infiltrative नहीं है. That's what it looks like. So choroidplexus के chance कम है. It turned out to be anaplastic ependymoma. So anaplastic was something that I did not expect so much. कि anaplastic होगा. I thought it would be more of a lower grade thing, but it turned out to be anaplastic ependymoma. Interesting, huh? Right? अच्छा, उसके बाद let's move on to this. This picture is actually not a good picture. This is a picture of central neurocytoma. I don't like this picture. This is rare that you find central neurocytoma like this. I'm going to skip it. This is from the Radiolopedia. This is more like a central neurocytoma. So now look at this picture. A T1. This is a T1 with contrast, T2 and flare, right? So it's somewhat homogeneous, arising from the walls of the ventricle. It's more in the body of lateral ventricle, but then not too different than this one, right? Not too different than this one. But this is anaplastic ependymoma, and this is central neurocytoma. So I'm sure I've confused you guys completely. I mean, they all look the same, right? And that's where the radiomics and radiogenomics comes into play, because there's subtle differences that I am unable to pick up and say with confidence कि ये है. So in this, if somebody said that it turns out to be neurocytoma, I'm a little surprised, because neurocytoma would arise more of frontal horn and the body. This is more of the atrium, right? So here ependymoma, meningioma, choroidplexus papilloma, those kind of things more common. And in the body over here, central neurocytoma, subependymoma, SEGA, those kind of things are more common over here. So this is by the Radiopedia. This is neurocytoma. अच्छा, उसके बाद this is this worth discussing? Maybe we can discuss a very complex case though. Let's see, maybe I should move to इसकी diagnosis. That's a complex. इसमें radiation वाला भी थी, तो I'll just skip that radiation necrosis. So yeah, this is something that I actually, we have cases. I didn't find the pictures. We just picked it up from somebody picked it up for me from internet. So remember this thing, that these central lesions, like what you see in here, both thalassemia. This is pediatric. ज़्यादा common है, and these are S3K27 mutation के साथ these midline gliomas. So remember those also. See this midline gliomas, and now it's being worked out more. Acha. Let's move on to this one. Here is another choroid plexus papilloma. We did discuss this one, right? Yes. Okay. We had done this one. Okay. So ependymoma. This is our subependymoma, right? Mustafa?
No, sir. No, sir. It was brought from Wikipedia.
Okay, all right. So this is the same picture on there. Okay, all right. Okay, here is a picture of subependymal giant cell astrocytoma. So if you notice that how it's arising from the wall, it is more in the frontal horn, right? More in the frontal horn, arising from the wall. So whenever you have, it will be SEGA or subependymoma and things like that. All right. And this is, oh shoot, I should not have medical record. So this was this, we showed actually picture. This was anaplastic ependymoma. All right. This is again coming from coming from Radiopedia or some other source like this. I wanted to tell you guys about the fourth ventricular tumor. हमने discuss पहले भी किया था. This actually is arising. यहाँ पे बड़ा clear लग रहा है कि it's arising from the floor of the fourth ventricle, and it's the dorsally exophytic parasitic astrocytoma, which is not a typical picture of parasitic astrocytoma. But let me show you something else. Okay, this is a gentleman with intraventricular lesion going into the foramen of Luschka over here, right? And this is the medulloblastoma. This is H type 2. Okay, so I wanted to just quickly touch this base with you on this one. So there are four kinds of medulloblastomas, right? And this is what we see in here. The differences: group 4, group 3, SHH, and Wnt. These are developmental genes, Wnt and sonic hedgehog. These genes are important from the very beginning of brain formation, but it's the same development. So what are tumors? There are all the developmental process gone out of control. That leads to tumors, right? Tumor is nothing else but our developmental process gone out of control. So these are the four subgroups: sonic hedgehog, Wnt, and group 4. So notice that the group 3 and group 4, they are pretty much in the center. Sonic hedgehog is more of cerebellar. Wnt is, getting more into the foramen of Luschka kind of thing, right? Lateral. So these two lateral. Sorry, क्या बोले?
सर मैं कह रहा था विंगलेस टाइप शायद सर्वर पेडिंकल्स की तरफ ज्यादा हो.
Peduncles and all that, exactly, right? So these two lateral and group 3, group 4. So group 3, group 4 और जो नाम है ये developmental sonic hedgehog and Wnt, right? So याद रहेगा group 3 group. इसमें उसमें जो तस्वीर थी जो दिखा रहा था मैं, उसमें Wnt और sonic hedgehog उस तरफ थे, इस तरफ है. खैर, just remember that. So Wnt और sonic hedgehog, again midline की तरफ जो जाएंगे वो group 3, group 4 होंगे, और उसमें जो है जो adults होंगे that will be more of group 4, and this is group 3 will be more of pediatric age, right? And Wnt and sonic hedgehog pretty much you can find in pediatric or adults. Infant में ज़्यादा sonic hedgehog शायद मिल सकता है. उसके बाद सो प्रोग्नोसिस अगर देखें, सो सबसे पुअर प्रोग्नोसिस जो है ना वो इसकी है, ग्रुप 3 की है. सो व्हेन यू हैव मिड लाइन, दोज आर बैड इन प्रोग्नोसिस. पुअर ग्रुप 3 का आ गया, इंटरमीडिएट ग्रुप 4 का आ गया, विच इज स्टिल नॉट गुड. जबकि ये अगर आ रहा है ना पेडंकल पे और जो है फोरामेन ऑफ रिश्का की तरफ जा रहा है, जो दिस इज a very good prognosis. Sonic hedgehog is also mixed, So ये मेरे ख्याल में ये पिक्चर जो है, if you see this picture, you will remember that, and that will help you. All right. Okay. So let's move on now. मेरे ख्याल में टाइम खत्म हो गया है. ये so सब ये एपेंडाइमोमा था. Again, ये actually Mustafa gave me this slide. इसमें मुस्तफ़ा आपने कहीं पे पॉइंट्स लिखे. Yeah, there you go. So एपेंडाइमोमा के वो 4 points. A single large tumor common in the first regional edema, periwinkle, large located lobar mass, central chunky calcification, right?
Yes.
Yeah. Okay. All right. Okay. Choroid plexus papilloma, intensely enhancing. We have done too many choroid plexus papilloma. Done. I'm sick and tired of choroid plexus papilloma. High-grade glioma tha ye. This was, rising from the and then cystic mass going inside. Right. So okay. Look at this lesion. ये कौन बताएगा इसको? This is too recent. So those who are working with me know, not those. Anybody else? क्या लगता है ये? Okay. मैं बोल देता हूँ चलो. So this is intraventricular lesion, and it is peripheral enhancing, central. Lot of edema around it. Lot of edema around it, right? I don't have its axial pictures, unfortunately. So I will go with the high grade glioma on this one, with edema and all this thing, and such mixed signal and flare. And so just the surface test. Look at this picture, and look at this image, and look at this, and I'll show you in a minute. So जो surface पे when we reach when we entered the ventricle, यहाँ पर हम यहाँ से गए थे. So when we reach the surface, this is the first picture, and then when we reach inside, that's the second picture. Okay, all right. So it's in the ventricle now. Surface is smooth. It has some petechial hemorrhages and all that thing. So that is automatically telling me it's a high grade lesion, glioma side पे जा रहा है, ठीक है? And as we took biopsy from there and we went inside, it's all necrotic tissue. So necrosis, इतनी ज़्यादा necrosis आ रही है, which looks like an MRI also, then it's a high-grade glioma, right? अच्छा, उसके बाद then further, I wanted to show this picture. If you notice this over here, ये suction tip है यहाँ पर. This is a blood vessel. These are a lot of blood vessels going around it, right? And here is a thrombosed vessel. And whenever I see a thrombosed vessel, I think about glioblastoma. Think about high-grade glioma, glioblastoma, things like that. So अभी इसकी final pathology आई नहीं है, लेकिन it's going to be most probably a GBM. But the MRI was telling us already a necrotic tissue, and different pattern of enhancement and all that. It has some high-grade glioma. Okay, so let's move on. I have actually 2 minutes now, so I think I will just quickly touch it. Okay, so this is again from my book of Anne Osborne, and Anne Osborne speaks very well also.
उन्होंने book भी लिखी हुई है. Yeah.
Right. तो उसी book से है ना ये, Anne Osborne की book से ये है. This was her first edition of neuroradiology. So actually Anne Osborne, I was introduced to. Well, I met her also at Henry Ford Hospital. Dr. Malik, my mentor. When we in residency, we were supposed to be a master of angiogram, and Anne Osborne की किताब थी angiography, छोटी सी किताब है. I still have it. If you guys want to have it and make a copy of it, it just you read that book. You can do it over a weekend, and you become a master of angiography, cerebral angiography. You have to be. So then she came up with this thing. So when she was early in her career, she wrote that one, which was very popular. But I don't know, that didn't follow. But this is one of the table from. So pineal region tumors, remember germ cell tumors, and then pineal cell tumors, panocytoma, pineoblastomas, and then everything else under the sun comes in there. So it can be cysts, it can be astrocytomas, it can be meningiomas, it can be metastasis and whatnot, right?